Good evening, all the respected delegates. My name is Ranjit Kadam, and I am Marketing Head of Pharmacare Division of Sun Pharma. Sun Pharma, being a #1 pharmaceutical company in India, always wants to associate and contribute in various scientific programs. In the past also, we had conducted several live surgical workshops and webinars to facilitate the knowledge sharing programs, and we are committed to do so in future as well. At Sun Pharma, we feel extremely proud to associate with such an eminent group of doctors from across the country. We feel extremely happy to inaugurate today a series of webinars which are going to be conducted once in a month. The main objective of this series is to concentrate on basics, which will be useful especially for PGs and young ENTs. In each series, we will have 2-3 eminent speakers, and the session is going to be moderated by the eminent panelists. For today's series, which is a series 1, it's our privilege to welcome today's speakers. So let me welcome first Dr. Srinivas Kishore. Welcome, sir. Dr. B. Jayaprakash Reddy. Welcome, sir, who are the speaker of today's session. I also welcome Dr. Srinath, who will be moderating today's session. Welcome, sir. Dr. Srinath is practicing at Anantapur for last 39 years and now the president of AOI AP state. Dr. Srinath has visited House Air Institute at Los Angeles and NHS Hospital, Wellington to learn advanced ENT surgeries. Also organized state ENT conferences on 2 occasions and regularly attending conferences and workshops and participating in scientific discussions like today's. Now, without taking much time, I hand over the session to Dr. Srinath to formally introduce our eminent speakers and to take them further and take them the proceedings of this entire program ahead, sir. So over to you, sir. Thank you very much. Yeah, over to you, Dr. Srinath.
Thank you, Kadam. Thank you, Kadam. I welcome all the delegates for this webinar on the basic concepts of ENT surgeries and ENT discussions. In this today's speaker, we have selected 2 persons. One is Srinivas Kishore, and then Jayaprakash Reddy from Kurnool. Srinivas Kishore is from Hyderabad. First, let me read the biodata of Srinivas Kishore. After that, he will have his scientific paper. Later, I will ask JP Reddy to present his paper. I know Dr. Srinivas Kishore for the last 20 years. He is a very good friend of mine and very jovial person, nice person, and then always smiling. That is the most important thing we can see from his face. He is working in the, right now he is working at the AIG hospitals and at Hyderabad. Previously he was working at Star Hospital and then Medicity Hospital in different places. Now at present he is at AIG Hospital, Hyderabad, and he is director of ENT and sleep apnea services, Hyderabad also. He is having very good experience in the obstructive sleep apnea surgeries and is very much interested in these surgeries. Especially pediatric OSA, he is already telling right now, he is very much interested in pediatric OSA. And he is having fellowship in endoscopic sinus surgery and workshop at the University of Pennsylvania in the year 2004 and 2005, and fellowship in sleep apnea surgery and Singapore also. And sleep apnea surgery and University of Wisconsin also. He has presented various papers regarding during all the scientific conferences. Mainly, some of the papers I will just list out his papers, which has presented already. That is, number 1 is AV malformations in the nose and a comparative study of management of auricular pseudocyst. Second is deep neck space infections in the diabetic patients and a comparative study of neonatal and adult larynx, pediatric glottic webs, laryngostecal stenosis management, and of course we can say OSA has presented a number of papers regarding OSA. Lastly, he has done everything in OSA, including the controversies in the management of OSA also. Now he is going to talk on coablation, the use of coablation, and what are the benefits of coablation surgery, and how to use in routine ENT practice. Now I request Dr. Srinivas Kishore to start his scientific paper on co-operation surgery. Carry on.
Can you hear me, sir?
Yeah, Jenny.
Good evening, everybody. At the outset, I would like to thank AOI AP for this very kind invitation, and always love to share my thoughts and experiences with all of you. I would like to also congratulate my co-speaker today, Dr. JP Reddy. And last but not the least, Mr. Ranjit Kadam and Sun Pharma for this fantastic platform that they have been always giving. I think right from the COVID, they've been at the helm of these things and constantly encouraging all of us and sharing knowledge wherever there is. Thank you very much, Mr. Ranjit and Sun Pharma, for this yet another initiative from you.
Thank you, sir. Thank you.
Without further delay, let me start sharing my presentation. Can you see my slides? Can you, Srinath,
Yes, sir.
can you see my slides?
Yes, sir. Yes, sir. Visible. Yes.
So today I'm going to talk to you all about coblation. And I've titled it, Everything You Need to Know About Coblation. I will try my level best to sort of bring out to you whatever every nitty-gritty that is there in terms of technology and in terms and ways and means of applying this particular technology. What I've decided to do is that because there are lots of wands that are available, I'm going to talk about each of these wands and the respective surgery that is best done with this particular wand. So at the end of this talk, probably most of you will have some idea, if not everything, about each of these technology, about each of these wands. So let me start my presentation. So all of you are surgeons, and all of you must be actually wondering at some point, what is an ideal operation, right? An ideal operation is something which is good in efficiency and efficacy. At the same time, it is safe. It should be simple and it should be easily reproducible. At the same time, it should be painless. I wouldn't say painless, but I would like to call it less pain, less bleeding, no loss of function, no morbidity and mortality. Now, this is an ideal operation according to me, and this is what came to me when I thought about conceptualizing this particular talk. I thought I should talk about what is an ideal operation. But unfortunately, you can't have all these things. Now, when you have this kind of an idea in mind, let's bring the whole discussion to what is so special about ENT surgeries, right? Now, when you talk about ENT surgeries, it is functionally essential areas. Every part of the human body that we deal with, especially the nose, the throat, the ear, these are functionally essential areas. You cannot mess out with essential areas because the problems are once there is any scarring that happens in these essential areas, it's going to be a mountainous or a huge task to deal with these things. Our areas, dear colleagues, are very rich in innervation, both when it comes to neuronal distribution, especially let it be the trigeminal, let it be the glossopharyngeal, it is very rich in innervation. And simultaneously, it's very highly vascular. And we share the airway with anesthesia. So that is what makes ENT surgeries very unique. So when you have such a lot of problems or special areas that you deal with, you need to have some kind of a technique and a technology that helps you at least address some of these problems. And that is where I think coblation comes in to answer most of these problems and these challenges that we face as ENT surgeons. Now, before going into the detail, like I said, for those of you nerds out there who would like to know all the nitty-gritties about coblation, coblation is actually a chemical process. And this chemical process is delivered in the form of what is called as a glow discharge plasma. So this glow discharge plasma is a very, very small plasma field, about 100 micrometers. It allows for precise volume removal. So coblation is primarily a volumetric reduction tool and not a cutting tool per se. Now you can use it as a cutting tool once you master the technology, but for beginners, please understand that this is a volume reduction tool. Yet it sort of gives imparts minimal thermal damage to untargeted tissue. That means there is not too much of collateral damage. So if you dissect the wand and see what is inside, I'm sure all of you must have seen and wondered what is inside this wand. So if you dissect this wand and look inside, they are basically active electrodes. The electrodes that you see, normally they are about 3 electrodes. And this is the basic EVOC wand that I'm talking about. The ProSize and the MLW, they work very differently. But if you look at the basic workhorse, basic wand, this is how it is. So you have the active electrodes, then you have the saline coming from the sheath. And once the saline falls on these electrodes, that is when the plasma gets generated. Now, the generation of plasma is not a single event, dear colleagues. It's actually 5 stages. But amongst all the 5 stages, it is the second stage that is very important, and it is called the stage of wafer film pulsation. That is when the tissue ablation happens. All right. The next stage is the reduction of amplitude across the electrodes. So once you go from second stage to third stage, there is a reduction in the current across the electrodes. Now, once the second stage is achieved, your tissue is not getting effectively ablated or cut. And that is why you need to have second stage going again and again and again. So in order to have a constant second stage, it is probably a good idea for you to go on and off. That means if you press the yellow pedal on and off, all these stages, all the 5 stages go in cycle. So if you continuously go, your coblation is not that effective, right? I hope this understands why people tell you to go on and off, on and off, on and off, to get the second stage more often so that you are a more effective ablator. Now, taking this a little more further, so this is a diagrammatic representation of what I just showed in a text format. You have the wand, you have the saline coming in. Once the saline, the electrode gets activated by pressing your yellow pedal, there is a current that is formed between the sheath, the saline coming out, the active electrode there, and then there is a return electrode. So there is a current cycle going on in that area. And once the ions have gotten activated, that is when you start using this electrode to ablate the tissue layer by layer. And that is what makes coblation very special. Now, what is happening to the tissue? Now, in this earlier slide, I showed you what is happening at the edge of the tip of the wand. Now, what is happening at the tip, in the tissue level? this plasma that has got generated at the end of the active electrode, the tissue that comes in contact with this plasma actually gets broken down. Okay, now what this tissue plasma does, it breaks the molecular bonds of these tissues. And at what temperature is this happening? This is happening at a temperature of about 40 to 70 degrees. Now, this is much, much lower than the temperature that you would get at the end of a tip of a radio frequency or a regular monopolar diathermy, or for that matter, the very hot laser. Now, that is what makes this special. But again, please remember, this is a volume reduction tool and not a cutting tool. Yes, you can harness this as a cutting tool once you master this particular technology. So I've spoken to you about what happens at the end of the wand, and I've spoken to you about what that, once the plasma is generated, what that impact is on the tissue level. Now a little bit of history. I think all of us need to be proud to say that this whole technology is a brainchild of an Indian, Hira Taplial, who migrated from India and settled in the Silicon Valley and brought out this technology. Now, just for those of you who are interested a little bit about this, coblation was never designed for ENT, right? It was basically designed for, you would be very surprised, to unclog arteries in patients with cardiac disease. But then they realized that the energy is too much to, and you would actually result in breaking the integrity of the cardiac vessels. Then they applied it in the most aggressive tissue that is available, which is bone. And then learning from there, they sort of came out with the applications for ENT, and then there is no looking back. So Arthrocare was further, which was the parent company, which later got bought out by Smith & Nephew, and which we now associate coblation to Smith & Nephew. Now, I would like to introduce the console. This is a console that all of you are very familiar with. So what is this basically? It's basically a radio frequency generator that operates at a very low rate of about 100 kilohertz. Now, those of you who use radio frequency, you know that it works at 5 to 6 megahertz. When compared to radio frequency, this is at a very low operating frequency, which is 100 kilohertz. Now, the generator is capable of adjusting the settings automatically based on the wand that you apply. And it has two basic settings, which comes in automatically, which is your yellow pedal, which is the coblation, and the blue pedal, which is the cauterization. Now, behold, the new coblation device, which is now coming out. By the end of this year, probably we will have the new Werewolf from Smith & Nephew. It is a fantastic tool. I've had the opportunity of seeing this in America. They have sort of answered all our problems that we had when we complained about problems of wands getting blocked and all this. This is called the Halo wand, which is got a big suction port, and it also has a return electrode behind. So come maybe November or December, we will have this new device it's a fantastic tool. So let me not give you all the surprises. Let's wait for it to come in. So let's also talk a few words about the wand. So the wand has basically 2 or 3 electrodes at the base, and these electrodes are separated by ceramic so that the saline can flow between this, because the plasma is generated between these electrodes. Now, what is very important and what makes coblation so special is because there is no, supposing you put any tissue beside it, right? Let it be an endotracheal tube or your tonsil dissector for that matter. electricity does not jump. And I'm sure most of you must have seen, if you put a monopolar diathermy and you put a metal device very close to it, current just jumps onto the device, onto the metal device, and it burns where the metal device is. That cannot happen with this kind of this coblation device. And that is what makes it superior when it comes to operating in the airway, because you don't have to choose a laser packed or a laser special airway. And I'll show you some of these airway procedures wherein you're almost on the endotracheal tube and you're not causing any damage to it. Another point about thermal damage, I think this is something that you should also understand. This is something that has been done on the beef heart. It basically shows that how once the blue pedal is pressed and once you put in the coblation wand settings, as you keep going up, the thermal damage, that is the thermal margin, is going down and the coblation effect is going up. So when you want to use very less, supposing you're operating on a neonate, it's probably a good idea to go with the default setting because it causes very less collateral damage, and also the thermal margin, as you can see here, is very, very less. As you increase the wand power, the thermal damage is also going down. This is something that is very important that you understand as novice surgeons, those of you who want to get into this technology now. And same thing goes for the thermal setting again. The amount of heat that you are delivering to the tissue would go down as you increase the coblation settings. Now, enough of this, and let's get into what these wands are all made of and what they can do. The first wand I would like to discuss to you all, with you about are the reflux wands, the reflux Ultra 45, the reflux SP, and the reflux 55. These are not coblation wands. These are actually wands that generate coblation or plasma in the tissue. These are unlike the EVAC wands or the ProSize wands or the LW wands. These are wands that generate plasma once you install it into the tissue. So how do you do this? So let's start with how the turbinoplasty wand, the EVAC 45, works. Since this does not have an inherent plasma that can produce plasma at the end of it, you have to soak the tissue that you want to ablate with plasma. So the plasma is generated in the tissue that you want to let the wand work. You fill up the tissue with plasma, then you enter into the tissue. Now, if you want more ablation, you can actually swirl it. And if you observe, these wands have markings on them. Each one of them basically designed to ablate each part of the inferior turbinate. So if you if you can see the third mark, that means you are ablating the distal end of the inferior turbinate. If you are seeing the two marks, that means you are ablating the middle part of the turbinate. And if you are seeing the distal marking, you are ablating the anterior end of the inferior turbinate. Please also remember when you are ablating this area that there are a lot of cold receptors in the anterior end of the inferior turbinate. So it's important that you don't burn them with too much tissue, too much radio frequency, or too much coblation. And that is where coblation scores, because there is very less collateral damage. There is very less chance that you would damage the cold receptors which are distributed on the anterior and the anterior superior end of the inferior turbinate. What about septal tubercle or septal swell body? Now, all of us know from rhinomanometric studies and fluid dynamic studies based on CBCT that about more than 60 to 70% of the air goes through the middle turbinate area and the middle meatus area. Now, if you have a septal tubercle like this, more common in children or in patients with allergic rhinitis, it is important that you actually direct the air blast or the draft of air into the middle meatus area. So, like I said, to ablate this particular septal tubercle or the septal swell body, we use the Reflex Ultra 55 wand also. Now, when you use the Reflex Ultra 55 wand, you know that this is not a plasma wand. So you want to generate the plasma in the tissue itself. So the area or the target where you want to apply needs to be filled or in fact overwhelmed with plasma. And once you do that, you basically will have to see now you've put in some local patty there. So now I'm just showing how this wand works. See, this is the tip of the Reflex Ultra wand. Now we are going in just a little proximal to it. Do not activate it till you are in the sweet spot, and then you activate it for about 10 seconds or 15 seconds at a time. Now, how would you know that your job is done? Gently tug your wand, right? Once you feel a resistance, that means the protein there got denatured or coagulated. So your wand is not coming out easily. But if your wand is coming out easily, that means that your protein denaturation has not happened. Maybe you'll have to ablate it for another 5 more seconds. Now, unlike radio frequency, wherein you see an immediate volume reduction, you don't see that happening in coblation. Coblation effect is a process and it takes time. Now let's talk about the Ultra SP wand. Now, Ultra SP wand is a sort of a plasma wand, but it does not have a suction. So it has a sheath wherein plasma is generated, and it has an active electrode at the end of the wand. Now, where do we use it? We use this a lot in sleep surgery. This is a drug-induced sleep endoscopy of a patient where you can see the salpingopharyngeal folds coming down like this. And where at the level of the velum, you can see how these hypertrophied salpingopharyngeal folds are coming in. You can very clearly see this is the salpingopharyngeal fold, this is the levator muscle. So what do? Same thing, you don't have to inject saline in this case because this wand is a sort of an elder brother, say, of the reflex wand, wherein it has its own plasma coming from the sheath. So you just insert into the tissue and this part gets volumetric reduction. Again, do not put more than 10 to 12 seconds, and over a period of time, because of the volume reduction that happens, you would get a volume reduction of the salpingopharyngeal fold. Now let's talk about the Reflex 55 wand that we use when you want to reduce the tongue base in patients who have absolute macroglossia. I'm just showing a cadaver dissection model just to show where all we apply, because I thought that this is a very apt picture to show you where all we apply. You can see the circumvallate papilla, 1 centimeter in front of the circumvallate papilla, one spot for 15 seconds, one spot in front of that, one more ablation, and one spot. Now this distal spot should be 2 centimeters from the tip of the tongue. Now, if you think you need more volume reduction, just draw a line along the circumvallate papillae, this is foramen cecum, this is circumvallate papillae, 1 centimeter lateral to it, you ablate, you can put in one spot with your reflex and one spot again. Now the direction should be not distal, but it should be towards the foramen cecum. And that is how this picture is showing and how you do it. Now, this is not a single setting procedure. You need to do it at least 3-4 times to get a meaningful result. Now, a few slides and videos about the EVAC 73 Extra, which is the workhorse for most of us who use coblation. Now, let's start with a simple procedure. This is a child with severe obstructive sleep apnea. And we are going ahead and doing an extracapsular tonsillectomy. When you can see there is absolutely no space between the tonsil. This child had severe OSA with an AHI of about 10. As you would know, that 10 AHI according to the pediatric scale is quite high. It's severe OSA. And you can see I am actually on purpose taking out an anterior pillar. And you can, and those of you who can see that I'm actually using the plasma. I'm not touching the tissue. Some people use the touch technique, and you can also see there is no black happening anywhere. Use it like a paintbrush. And the whole thing is about traction and counter traction. And you can see how we are using this coblation with how we are using the plasma. And if you can actually appreciate, I am not touching the tissue. I am not staying at one point. I'm constantly changing, and there is hardly any space here in this particular child. But with multiple strokes and multiple tractions, we're going ahead and doing the procedure. Now, let me just fast forward to, this is the opposite side. Can you actually appreciate the fibers? I would actually urge all of you, when you do tonsillectomies, please use a microscope or at least any kind of magnifying device, at least loupes or anything close to that. Because there is a lot of literature out there that would basically say that using loupes or using magnification actually improves outcomes in adenotonsillectomy. Now you can see with both the tonsils out, all the amount of space that is come for this particular child. And you can see there is hardly any black happening. There is hardly any charring happening. And this patient is absolutely cured of the obstructive sleep apnea. But when it comes to extracapsular tonsillectomy, and when you talk about coblation, one thing that dreads us is secondary hemorrhage. And those of us who have done enough tonsillectomies know that secondary hemorrhage is something that we are very, very scared of. Now, I just want to show you this particular video. This is a child, almost 12th day of adenotonsillectomy done, pediatric OSA child. And this is in the night. Child came with it. Now pay attention. I'm trying to, there. So you know that once you see this kind of a picture, you know that there is an active vessel just below the anterior pillar. Now, this is, you're already tensed. It's very important, and most of us would like to just take the bipolar and go ahead and take care of that bleeder. Let me just play this. So the moment I lift the clot, You know that, and you should be very, very careful in pediatric age group, because the blood volume is not too much. And don't feel that, you know, the coblation will not work. It's a secondary hemorrhage. No, don't even think that. Use the coblation, use the same wand, and please remember, coblation is such a fantastic tool. It has suction, it has dissection, it has irrigation, and slowly dissect the clot away from the field and expose. Now, most of the times, this is what you would see, right? You won't be, because by then, the anesthesia would have set in, the pressure must have gone down. It looks very, very benign. But please don't get fooled by it. There is always a vessel that is below, lying below the inferior aspect of the, there you can see, the inferior aspect of the anterior pillar. And you will have to avert that margin to see that, because these are what? These are descending branches. These are the branches of the descending palatine. This is not your regular tonsillar artery. These things don't bleed that much. It is the branches of the descending palatine. So in such cases, you should not worry, and you should not go ahead, ablate or cut the anterior, the medially arching fibers of the palatoglossus, and you will see the, do not shy to cut the medially arching fibers of the palatoglossus. Just go ahead, you will see the bleeder, because it is on the inferior aspect of it, right? And ablate it. Now, what about adult? Adult secondary hemorrhage after tonsillectomy with coblation is another dreaded problem. You know, this is, again, most of us are terribly scared of even doing an adult a pediatric tonsillectomy. Forget doing, adult tonsillectomy with coblation. This is an adult tonsillectomy again, wherein you can see this part again, day 12, day 13. These patients never, when you see a clot, never shun away from it. It is probably a good idea to take these patients, especially when you have operated with coblation. Now, why I'm showing this video is coblation heals in a very special way. I want to actually show you the velvety appearance that a healed coblation tonsil cavity gives you. And most of you who have used coblation must have seen this cavity. Coblation doesn't heal in a very regular slough way. It causes this the very velvety kind of a tissue which is very friable. In fact, it is this property of the coblation that actually people have been using to treat diabetic foot, because it causes a lot of neovascularization. You see this bed and you see this typical cobblestoning velvety appearance. Now, when people, by the time they cross day 10, day 11, they get very confident, right? And they start eating all kinds of things. And even when tissue rubs against this velvety tissue, it starts bleeding and you get called in the middle of the night. See, this is not an artery. It is all the velvety tissue that is bleeding. So just take your coblation evac wand and start coagulating all that area. Please put in at least, see, when you use your blue pedal, the instruction is not to touch and go, but to touch and count for 4 seconds. And the more you press and the longer you put, the better the coagulation is. Remember, the rules for coagulation and coblation are very different. For coagulation, the longer you put in and the at least for 4 seconds, it's better. And that's how you go ahead and cauterize that whole area. Now, because of this dreaded complication, the entire West, and now totally in India also, we have moved to what is now called subcapsular tonsillectomy. Subcapsular tonsillectomy for not only for OSA, but also for tonsil stones, also for chronic tonsillitis. Now, there is enough evidence that is out there that shows that this kind of tonsillectomy scores not only in terms of pain reduction, but also in terms of secondary hemorrhage. All of you know that secondary hemorrhage from any hot technique is about 4 to 6%. The moment you shift from extracapsular to subcapsular tonsillectomy, your secondary hemorrhage rates are falling to 1.6%. Where is 6% and where is 1.6%? Even the pain scores significantly fall down. Now, the biggest problem for choosing subcapsular tonsillectomy is what? Recurrence rate. And it has been shown that the recurrence rate after subcapsular tonsillectomy, after the age of 5 years, is what? Is a mere 4 to 5%. So when you have a recurrence rate of 4 to 5%, as opposed to a secondary hemorrhage rate of 1.6%, please do your math. I think this is a logical procedure to do. Completely shift from extracapsular to subcapsular. This is a faster procedure, a gentler procedure, a quicker procedure, and a safer procedure to do. Right? Now, at this juncture, I would like to introduce two types of subcapsular tonsillectomy, type 1 and type 2. Type 1 is when you stop at the level of the anterior pillar. That is type 1 kind of subcapsular tonsillectomy. Type 2 is when you actually go and define the pharyngobasilar fascia, and that is type 2. The recurrence rates for type 1 are higher. So please do a type 2 wherein you can actually define the pharyngobasilar fascia. That makes it, now defining this particular fascia is much easier when you do a subcapsular tonsillectomy under magnification. And that's what makes it even better. Now, these patients start eating in the next 1 hour, and then you can send them home also in the next 1 hour. Now, adenoidectomy is another procedure that that these wands do miraculously. This is another OSA child. You see that there is absolutely no space that is available. And this is another challenge that most of us are facing when you have severe OSA children. Do not worry about that. You have an intrachoanal adenoid tissue. Use your infant feeding tubes. Take the palate upwards, and using a pediatric scope, go ahead. Always see the face of your tissue, of your wand. Now, this is something that I have against a lot of people in the West. They use and they approach it from the palate. Now, when you're approaching the and putting the scope from the palate, you are not seeing what the face of your wand is doing. Your wand is on the other side and doing its job. No matter it's a microdebrider, or it's a radio frequency device, or a regular monopolar diathermy, don't you think it's important that you see the active part of of your electrode, what it's doing? It is always important, and hence this kind of approach and putting the scope from the nose always helps. Now you can see I'm using this wand in two kinds of strokes. Now, if I have a bleeding, I'm going with a horizontal stroke. If I want active ablation, very quick ablation to happen, I am using a vertical stroke. Do not worry about these little bleeds. Do not stop. Keep ablating the tissue, keep ablating the tissue. And this procedure is in real time, dear colleagues. This is in 2 minutes. We have basically pulverized the huge adenoid that was there. And I will fast forward it to the other side as well. And you can now see in almost 5 minutes, we have finished the adenoidectomy. It's not about the speed, it's about how effectively you can do it. Now you can see the fascia, we have defined it, and you want, but do not get stuck in one point. That is what I would like to urge our junior colleagues. Just horizontal strokes, don't get stuck in one point. If you get stuck in one point, the tissue gets clogged in the port, and that's the end of it. So the moment you get a twitch is when you stop. Now, there are a lot of palatal surgeries that we used to do with coblation before, but now with the use of a minimalistic approach is now what is in use nowadays. We don't use all these palatopharyngeal flaps. We don't use all these zeta palatoplasties nowadays, gone are those days. But yes, when we did these procedures, coblation was a fantastic device. But when it comes to tongue base, nothing like coblation. Now, I want to demonstrate how coblation actually helps getting rid of. This is a grade 3 kind of a lingual tonsil. And this is how the entire lingual tonsil is ablated. I have actually, because of time, I fast forwarded the whole thing. Now you could actually see the whole idea is to delineate the vallicula. That is when you stop it. And again, see, there is hardly any black that is happening anywhere. The idea is to ablate it right from the foramen cecum to the vallicula. And you can see, I just want you to look at and appreciate how the plasma is working. And in a non-touch technique, it is ablating your lingual tonsils. Do not touch it, dear colleagues. If you touch it, you are not using the beauty of your coblation wand. Now, you can also use it in rhinology, especially when you want to denude that area, when you don't want function. Please don't use it for FES, because it has been shown that if you use the coblation for anything that is functional, the mucosa is completely gone. But here in CSF leaks, you can use it. This is the frontal sinus. This is the skull base. You want that area to get raw. This is a fantastic tool to do that, because this is an area where you want irrigation, you want ablation, you want the mucosa there to get burnt, because whatever graft that's the olfactory fiber, and you can see the raw area there. And coblation completely fits in that to that menu. Now, once this is done, you can use whatever tissue or whatever, whether it's fat or whatever that you want to do to close that area. No other tool gives that kind of a fantastic, see how I'm using the wand. Never touch it. Always use the side of the wand. Use the return electrode to your advantage, and you can actually see the bony defect there, and you can see the dura there. This is the septum. And once you create such kind of a good raw area, you can actually use any kind of a tissue to seal it up. See, now I'm putting fat, and of course, the rest, all of you know. Now, sometimes you are called in for uncontrolled epistaxis. Here is a patient with very high pressures, and you can see sphenopalatine bleed that is happening. And this is a fantastic tool to actually ablate it and control the bleed. You can see don't get stressed if it's not, if you're not gotten it in the first time. Please be patient, and the patient is anesthetized, so there's nothing to be worried about. Take your time. Coblation works, right? Slowly now you can see how we have controlled the bleed, and now you can slowly, since now that the bleeding has completely stopped, you can take your time and slowly delineate and cauterize the artery again. This is, you can see so much of mucosal damage that's happened because the patient was packed elsewhere. But with this beautiful tool, you can actually ablate that and control the bleeding very, very effectively. This was a 78-year-old patient that was transported for us just to control bleed. Now, once you...
Hello, Kishore.
How much time do I have?
I think time is approaching. Please brief.
Yes, yes, sir. That's what. Okay. That's why I wanted you to tell me before. So now I'll rush.
Okay.
This is the ProSize Max wand that we use again to. This is tongue base. Again, see how the ProSize wand, it gets irrigation from the tongue, and you're actually creating a raw area on the lingual surface of the epiglottis. These are massive tongue-based resections that you can do with for sleep apnea. For want of time, I will fast forward this. The turbinator, I will skip. Yes, a few words about the laryngeal wand. This is the ProSize MLW wand. This is a fantastic tool to do pediatric work. This is a child which is 1 month old, for whom the child had severe laryngomalacia, type 1 or type 2 laryngomalacia. So we're using this MLW wand. The indication for supraglottoplasty for laryngomalacia is 1, apparent life-threatening events, 2 is failure to thrive, right? So we're using this very nice wand to create a raw area. And for want of time, let me just fast forward this. And I would like to show how gentle this tissue, this wand is. And I just would like to show you, see, now on, off. When it comes to coblation, especially in infants, on and off. So once very gently, you can also use a scissors and snip it off. But then this is such a fantastic device that it does not cause any kind of collateral damage. So you can see this side has the area epiglottic fold is intact, and this side we have released. And how beautifully the entire larynx just opens up like a flower. And there is an artery that goes in this fold. When you use coblation, that artery is completely ablated. Now you can see this, and ablate it till you get that artery. Now, what about chordotomies? Again, you can use the same wand to use, this is an MLW wand. The posterior part of the vocal cord is where you get the air. You have no business to touch the front portion. You start off with the from the anterior end of the vocal process, and you will have to keep going up to the, let me fast forward this, right? The inferior end, your limit of dissection is 1, inferiorly the cricoid cartilage, and then lateral extension is the thyroid cartilage. And layer by layer, you can go ahead and with this beautiful wand, because it also irrigates the tissue where it goes, right? And you can see how the active electrode is ablating that blood that's coming there. This is a fantastic tool to do resection surgery in the larynx. Now I've gone and completely ablated the false cords as well. Your limit of dissection, where you stop, is once you expose the thyroid ala. You can see that my colleague is pressing the ala from outside, and that is your limit of dissection. This is the ala of the thyroid cartilage. This is the cricoid cartilage. Now, you can also use this for telangiectatic polyps. Again, MLW wand. It's a very, very gentle kind of a tissue. You can gently dissect and ablate it. But the best use of this technology is in areas like supraglottic stenosis. This is a patient wherein who had complete, this is the tongue base, this is the uvula, and this is a 16-year-old who had taken poison because she didn't get good marks in her 10th grade. This is for want of time. Let me just, we are using the MLW wand. We've used, so this is how now we are creating, now this is the laryngeal inlet. You can see how thick the scar is. This is the piriform fossa that we are creating. And we're using a laryngeal spreader to basically see and create. There's absolutely no piriform fossa. We're using the MLW wand here. And now you can see her larynx. And then this is the suprastomal granuloma. This child had to be tracheostomized, obviously, which was also ablated in the same time. And this is 3 weeks post-op. This is how it was. This is 6 weeks post-op. This is how it has beautifully healed and mucosalized. And this is 2 years post-op. This is flexible scopy. This child is now doing law and is doing fantastically. You can see the gastro colleagues have also done a pull-up. This is the colonic stoma and is doing very well. This is another patient operated elsewhere in Egypt and came with supraglottic stenosis. Again, same principle. And you can see how thick the scar is and how beautifully the MLW wand can take care of the scar. Now, let me just fast forward the whole thing. And also gives very good results after putting. Now, this is the same patient 3 months post-op. You can see how beautifully it has mucosalized. The trick is to be very conservative, use plasma, don't burn the tissue. This is subglottic stenosis for a patient of vaginous granulomatosis. Always take a biopsy before using coblation. For want of time, let me fast forward the whole thing. This is a primary epiglottic collapse wherein you use coblation to remove the mucosa on the lingual surface of the epiglottis. And once that is done, then you can use any kind of tool to take the suprahyoid epiglottis out. This is a post-op and this is 3 months post-op. So how does one get the best out of coblation? Intermittent application of the ablation mode, copious irrigation. I use a lot of cold saline and using the pressure bag always helps. And when there is bleed, do not go to the blue pedal. Use the yellow pedal, use coblation to your advantage and use plasma and it automatically stops. Hover around that area and that's the best thing that I have learned. Just keep hovering, use plasma and it completely stops. Smoke coblation is a smokeless procedure. If you're getting smoke, that means that is tissue in between the electrodes. A smoking wand should be flushed. Use a toothbrush to clear the electrodes. During coblation, the surgery, the tissue could be seen turning brown. This does not mean that you're charring the tissue. There is oxidation, that is the OH of the plasma that is causing this. Don't worry. The coblation, the generated frequency from the coblator is actually a 200 Hz frequency. Sometimes you would also see that your tissue is also sort of, you're getting twitchings. That means that the depth of anesthesia is not that great. So if you want to use the blue pedal, that's what I was trying to tell you. Increase the amount of time, keep the tissue pressed. These are tips for using the blue pedal. The earlier were tips for using the yellow pedal. Suction and irrigation are your winners. This is what makes your coblation surgery succeed or fail. Thank you very much, dear colleagues, and thank you for the opportunity again.
Thank you, Dr. Srinivas Kishore. Thank you, Dr. Kishore. Your very much informative lecture on coblation, basic principles, and then applications of coblation in ENT practice. Thank you, Dr. Kishore.
Thank you, sir.
The next speaker is Dr. Bhumireddy Jayaprakash Reddy. He is a very good friend of mine, Jayaprakash Reddy. At present, he is the Vice President of AOI Andhra Pradesh. He is having 23 years experience in the and is consultant of Satyasai Institute of ENT Hospital and Kurnool. He has conducted 27 workshops on temporal bone dissection and live surgeries. Every year he is doing, and he has done fellowships in otology under the care of Andhra Sultan in Paris. He has presented many papers and then more than 170 papers at various conferences and conducted many panel discussions and workshops. As he is very much interested in micro-ear surgery and also pediatric bronchoscopy. Thank you. Now I request Jayaprakash Reddy to start his lecture on applications of coblation in some rare situations.
Good evening, everyone. Am I audible, sir? Hello?
Audible for me.
Yes, you are audible, JP.
Yeah, okay. Thank you very much. Before I start my session, actually, I thank the Sunpharma people for taking up this task of holding these webinars on a regular basis, which will be beneficial for the junior colleagues. And I also thank Dr. Srinivas Kishore for his excellent talk on coblation, which are really a lot of very good tips that we have learned today. And I just want to add on to his lecture, and I'm not going to tell you about how the coblation works and what are the wands available, and everything was actually discussed very much by Dr. Srinivas Kishore. I just want to tell only a few words as to when the coblation really then works in it. We all know that there are many critical situations during surgery, especially when you are operating. So the most critical situation that we come across is the bleeding. So we are all worried about bleeding in our practice. So there are very good tools to control the intraoperative hemorrhage. We have radio frequency, we have diathermy, and we have laser. We have so many things, but the ability of coblation in a critical situation where a single instrument that can do 5 functions at once is the only coblation. So it will suck, it will irrigate, it will coagulate. If you want, you can ablate. And the most critical point that I want to stress here is that what all you can see in the nose, you cannot reach actually. Your forceps or your bipolar forceps or your so many forceps cannot reach, but the single instrument that can reach any area that you want by bending the wand, you can reach. So with these 5 very good qualities, I can rate this coblation as a very good tool in our ENT practice. So now you see this patient actually had come to me with the anterior nasal packing, which is changed, and they remove the pack. After 5 minutes, the patient bleeds, and they are not identified from where the bleeder was. So then I took the patient general anesthesia. Then I see there is a profuse bleeding in the sphenoethmoidal recess. You can see the blood is just flowing like that. So now Can you hear me, please? Hello?
Yes, sir. Yes, sir.
Yes,
Yeah.
Jay, we can hear you.
Yeah, see, I could go inside and I would identify the bleeder. But now, when I want to control this bleeder with bipolar diathermy, you can see that what's happening. The bleeding is coming in. I am unable to identify the bleeder. At the same time, as I go inside, my both this jaws of the bipolar are getting closed against each other, so that I cannot coagulate at the place where exactly I want. This is the place where I wanted to actually coagulate, but I am unable to do so because of the simple reason that the instrument will not reach to that place. So now you can see the difference that was the coblation. So now I have gone to the place where it is exactly bleeding, and you can see with one I could control the bleeder in the sphenoethmoidal recess, where the vision is clear and the wand is sucking the blood and making the field very clean, and I could control the bleeder very effectively with the wand, and I have not packed this patient post-operatively. So once you control the bleeding, there is no need to pack the post-operative the nose again. See, with 4 touches, the complete bleeding was controlled. So this is how the coblation will come for the rescue. Now you see, when you do a sphenoidotomy, we all know that there is one artery which traverses the anterior face of the sphenoid, that is the posterior septal artery. When I want to see, you can see it bleeds from lateral to medial. You can see in a while enlarging the sphenoethmoidal os here, you can see the bleeding will start here. See, it is bleeding so. So the best instrument here is, again, if you can reach this area, then you can do with a bipolar. But bipolar will not be so effective in such a inside crevices like that. So now you can see this is sucking, and this just job in few seconds. That's all. So that is the beauty of coblation. See, again, this patient, I did a septoplasty and a minimal fess for the anterior sinuses. You can see the patient had continuous bleeding in the post-operative in the evening. The one bleeder was from the superior part of the uncinate process here, and which could be controlled with the bipolar. And again, I could see another bleeder from the posterior end of the middle meatus. You can see a lot of bleeding was there. So I waited for about almost half an hour or so by changing the packs, but the bleeding was profuse and continuous. So I took this patient again into the operation room, and then I could see a lot of bleeding which was coming from the posterior end of the posterior frontal leg, because always there is a vessel which runs here. Again, I tried with the bipolar forceps. It goes there and it cannot effectively control the bleeding, because I can see now, you can see I took the wand, and then you can see it was bleeding from the posterior end of the max. See, now once in the post-operative, once the bleeding is controlled, there was no need for me to pack again. So the effectiveness of the wand in such a way that it controls, you can suck the bleeder, you can suck, identify the bleeder, and you can touch and come out. Again, there is a arterial spurt in a hypertensive patient. You can see from a superior most part of the septum, which could be just controlled with few just touches like that. And I don't think our bipolar will be so effective in controlling the bleeding. Yes, you can try, but those who doesn't have coblation can always use a bipolar, but nothing like, so there is no need of packing, there is no need of anything once you control the bleeder like this. So it does job in few seconds of time. So now this is again a severe post-operative hypertensive bleed. I just want to share this. This was a VIP, another big politician in our area, where he was on actually blood thinners, and he was having profuse bleeding from the sphenoethmoidal area, and the anesthetist was unable to anesthetize He was afraid because he was a VVIP, and you can see the bleeder was so much so that, and the patient was not allowing me to do anything without anesthesia. So what I could do was that if you give anesthesia, it's like a child's play, you can control the bleeding. But the anesthetist was reluctant because of his VIP, and it was a small setup. So we could just control the bleeding with the pack, and the rest was done elsewhere. So this can also be done in an emergency. Coblation will work. Especially, see, whatever you want to do, the patient should be standstill. Especially if you give anesthesia, then you can control the bleeding effectively. But in a struggling patient, to control bleeding is not so simple. So this patient, again, I want to tell you something, that a patient who is hypertensive, having lots of posterior bleeding, is always from the inferior meatus. A vessel is there in the inferior meatus. You can see in this patient, it is like a tap. So you can say, the moment I suck, yeah, it comes. So this recording is in the outpatient. So once I took the patient to operation room, see, it was bleeding here from the posterior most part of the inferior meatus. So again, I used a coblation to control the bleeding. So coblation, no structure, no instrument will go to such a small crevices. And again, this patient had a post-operative, this sphenoidotomy was done, and from the anterior face of the sphenoid, patient has bleeding. So all these bleeders will come in the early mornings, at about 4 o'clock or in the midnight, which will be really scary, especially when you are practicing alone. If you are in a team, you can do. But even if you are alone, practicing alone, if you have a good tool like this, then you'll be having a lot of courage to handle such situations. How I am doing. See, now you can see that the bleeder would be controlled with a few buzzes like that. It was done almost 3 a.m. in the morning. Yeah, again, you can do a very good job with a small, this kind of a hemangiomas can be dealt with very easily with the coblation. And I just want to share one case where you can see this patient had pain and persistent hawking sensation in the throat. He had a small benign tumor-like thing here on the laryngeal surface of the epiglottis. So nothing like coblation that you can control very nicely. I wanted to do some kind of a cold steel instrument, but once the patient is intubated, hardly there is any place to handle the lesion. So I took the wand, laryngeal wand, and I removed the lesion very easily without any bleeding or without any post-operative complications. Just it is the matter of the precise ablation that the wand does. I don't think any other instrument we can handle this lesion so easily and effectively. So that is the beauty of the wand. Again, I just want to share a few words about this Kashima procedure. See, when you completely do Kashima procedure, see, a vessel will come here, which is a branch of inferior laryngeal vessel. So it bleeds like that. And I think the best tool to control the bleeding would be the wand that you are using than any instrument. I just want to share this vessel will be always there when you open up the larynx. And this particular condition we come across, you can see this laryngeal papillomatosis in an adult, which is completely blocking the larynx. The only solution is to do a tracheostomy and then do ablation. But if you do tracheostomy, I know you all know that there will be a lot of papilloma will occur on the stoma. So now I took this patient with the consent of the patient. We intubated the patient, and now you see a lot of bleeding is there, and there is no room in the larynx no landmarks, nothing. So in this sort of scenario, the removal of the lesion should be quick with your wand. And if you have a lot of bleeding like this because of the neovascularization, you should also have coblator wand with you. You can see the bleeding, the amount of bleeding that you can see here, that hardly there is any place to work. So the pressure will stop to some extent, and always you should have a laryngeal wand at your rescue. You can see a lot of bleeding was there. At middle of the procedure, I thought so many times whether to continue the procedure or to abandon. You can see that a lot of bleeding was there, which I could control effectively with the laryngeal wand, and I did the procedure. So the laryngeal wand, see, This place, the laryngeal, the in between the tube and the larynx, there is a papilloma is there, so which could be effectively removed with the laryngeal wand. So I don't think debrider can remove this part of the thing. So I just conclude my talk by just saying that the laryngeal wand is a very good tool, and it is versatile, and it is very useful both in elective as well as in emergencies when you come across. The only instrument that can do 4 functions simultaneously, that is, it will suck that what exactly you want to ablate, that will show you, where the bipolar has also got suction, but it's not so effective one like this, and it irrigates, it removes the blood clots and secretions. And if you want, you can ablate. See, the Kishore was telling that you hoe around the bleeder where you, that's called as hoeing around. See, if you keep the in ablation mode and then move over the bleeder without touching the tissue, it effectively seals the vessels and blocks the vessels and stops the bleeding. And it can also coagulate very effectively. So just 5 days back, I had a patient who had a secondary hemorrhage following tonsillectomy in a 7-year-old boy. And again, we took the patient in the, all emergencies come in the night. So it was very scary, actually, the amount of bleeding was there. So, and it could be effectively controlled with the coablation again, and the patient is doing well. So this is all that I wanted to say. Thank you very much for your kind attention.
Hello, thank you, Dr. Jayaprakash Reddy. Especially your application of coablation in the narrowest points where epistaxis is coming is a very nice thing. I thank you for your kind presentation. There are only 2 questions from the audience. Sanjay Bhagat from Gondla asked, sir, for microscope, where use 250 objective lens or 400 objective lens? Srinivas Kishore.
Ideal is 300, sir.
300 is a better thing. Oh, okay. In others are compliments only. Krishnan from Vishakhapatnam has complimented. That was nice presentation, Srinivas Kishore. And Ranjana Kumar also complimented. And one person from Balakishan from Chennai has asked to send the recording of this this webinar to Kadam. You please be on that line. I think there are not much questions. That means the audience has understood all the things what the 2 speakers has told. These are very good speakers, and they have briefly narrated about the coablation in a nutshell. So audience might have been benefited by this. Thank you, audience. Before thanking audience, let me thank Ranjan Kadam from Sun Pharma for giving an opportunity. And also the brain behind this, for this is mainly Jayaprakash Reddy. Though Sun Pharma has done the other work, the brain is Jayaprakash Reddy. I thank Jayaprakash Reddy also.
Absolutely. Yeah.
In future also, we'll do such webinars once or twice in a month. I request all the AOI members to be in touch always with these webinars. Thank you, one and all. Thank you.
Thank you.
Ranjit, you want to say something?
Yeah, I just want to thank only. Of course, good evening, everybody. Once again, Ranjit Kadam, this side from Pharmacare, Division Sun Pharma, and it was really very enriching, I would like to say. I thank today's eminent speakers, Dr. Srinivas Kishore and Dr. B. Jayaprakash Reddy, for very impressive and very informative talk. And I'm very sure this is going to help so many patients ultimately. And I also thank Dr. Srinath for navigating the entire session so effortlessly. I'm sure this program is definitely going to be a very wonderful series.
Yeah, before we conclude, I just want to thank Srinivas Kishore for enlightening us with very, very practical points. And every time we come across this coablation technology, I learn a new point. Today also, whether how many people have learned how many points, but I have learned a lot of things, practical issues, which the Srinivas Kishore has vast experience in using, and I can say is one of the pioneer in using this coablation technology in our part of India. Thank you very much, Srinivas Kishore. And
very much
thank
for
you.
your kind words. Thank you.
Thank you.
Thank you, Kishore.
Thank you, sir.
Oh, thank you.
Everyone.